In Australia and New Zealand, the number of people being diagnosed with breast cancer is increasing. In fact, the Australian Institute of Health and Welfare estimates that this year, breast cancer will become the most commonly diagnosed cancer in Australia, taking over from prostate cancer. This means more than 19,000 people in Australia and 3,500 people in New Zealand will receive a breast cancer diagnosis this year. However, the breast cancer mortality rate is in decline, which means less people are dying from this disease. To help make sense of this data, we sat down with Associate Professor Nicholas Wilcken, a medical oncologist and breast cancer trials board member. We asked him if we know why the number of women and men being diagnosed with breast cancer is increasing.
We know some of the reasons, yeah. As a sort of a shortcut, breast cancer is in some ways a disease of affluence. Not meaning that poor women don't get breast cancer, but meaning that when you compare rich parts of a country with poor parts of a country, or rich countries versus poor countries, or poor countries that are getting richer, like China, say, what you find is as you become more affluent, you get more breast cancer. And that's thought to be due to a number of factors. Some of them are kind of reproductive factors. So as you live, as we do, in a better nourished world, so we're not starving, we're not losing weight, all that sort of stuff, what you actually find is the age at which women first start getting their periods gets lower. So in Australia, average is sort of 12 or something. If you go to a poor rural part of China, it's more like 17 or 18. And that has an impact. That does slightly increase the risk of breast cancer. Similarly, menopause might be a bit later, and that slightly increases the risk. And then also our sort of pattern of childbearing changes. So in more impoverished countries, women tend to get pregnant very early, and that makes breast cancer less likely. I'm not obviously suggesting that getting pregnant very early is a good idea, but what happens, say, as a country becomes more westernised is that women have children later and later for obvious good reasons, but that does slightly increase your risk of breast cancer. And again, if you're in a poor country in, say, Africa or something, you will do a lot of breastfeeding, and you'll breastfeed each child for 2 or 3 years, and that's protective, whereas we tend not to do that, say, in Australia. So there's a whole lot of factors, most of which we can't do much about, that mean that as you get more healthy in other ways and wealthy society, you get more breast cancer. There's also a dietary component, but it's a little hard to pin down exactly what that is. But there's no doubt that if you live in a country where there's not enough food to eat and you're very thin, which is obviously not a good idea, the breast cancer rate's a lot lower. The way we would translate that into a health message now is, rather than being too concerned about exactly what you're eating, having a normal, regular, healthy diet and keeping an eye on the weight is helpful in reducing the risk of breast cancer.
And does the ageing population contribute to that number as well?
To an extent, the ageing population does. Obviously, if you don't die of pneumonia when you're a kid or a heart attack when you're middle-aged and you're going to live for longer, you've got a bigger chance of getting breast cancer. But I think the main drivers are those hormonal factors to do with periods, childbirth, all that stuff, and being overnourished.
So the number is increasing of diagnosis of breast cancer, but the number of deaths is decreasing. What can we attribute that to? So
yes, you're right. The number of deaths has decreased massively. So over the last sort of 25 years, the mortality rate, corrected per capita, has fallen by about 25%. And most of that is actually due to clinical trials showing that giving drug treatments after breast surgery reduces the risk of the cancer coming back. So it's mostly to do with drug treatments, and we've only known about that because of clinical trials. There's also probably a component of screening, so the more screening you have, the more likely you are to find cancers a bit earlier, and some of those you'll find early enough that you've cured the woman that you otherwise wouldn't have. But most commentators and most modelling will suggest that the biggest effect has been on effective drug therapy.
And are we optimistic about that number continuing to decline?
The number will continue to decline, although I think we've seen the biggest decline now, since about 1990, when these treatments started being used regularly. We've had a big fall from, say, 1990 to 2015, and we'll continue to have falls, but it'll be at a slower rate. In other words, we've done a lot of the heavy lifting. There's obviously more to do, and that'll be slow incremental benefits. I guess it's worth remembering that mortality figures, if I've got breast cancer, what are my chances of dying of breast cancer, is obviously an extremely important question. But there are other improvements that we've managed to attain through clinical trials that don't necessarily show up in survival statistics. So the experience of getting breast cancer is obviously very challenging, but it's gradually getting much easier to manage than it was, say, 20 years ago, for a whole bunch of reasons. The drugs are smarter, the anti-nausea medications are better, the pain medications are better, and so on. So some people, obviously, I know, have a big struggle with breast cancer, because I see women with breast cancer pretty well every day of my working life. But the experience is less troubling and less difficult than it was 25 years ago. So there are improvements in survival. Obviously, that's critical, but there are other improvements. If you only look at survival, you'll miss some of the other improvements.
So the quality of life improvements.
Yes, exactly. Yeah.
And what are some common questions that you get from patients in your everyday? You said you can see up to 30 patients a day. When somebody gets a diagnosis, is a common question to ask about the mortality rate, or are there other common questions that you get asked?
I think when women are first diagnosed, they're mainly asking short-term questions. It's a time of amazing stress, obviously, and they're not able to take everything in that's told to them, which is why it's always good to have someone with them. But they're going to be more focused on, what do you mean? How do you know? Are you sure? Why did it happen to me? What sort of operation do I have? Do I need to have chemotherapy? Will my hair fall out? Those sort of, short-term but obviously incredibly important questions. Questions about survival chances and so on tend to come a little bit later. You've had your operation, the surgeon has explained what she found and has said, I want you to go and see the chemotherapy doctor to talk about whether you need chemotherapy or not, which is where I come in. And then I do have to explain to the woman, look, there's such and such a chance that this could come back. That's why we think that you do, or in some cases you do not, need chemotherapy.
That was Associate Professor Nicholas Wilcken, a medical oncologist and breast cancer trials board member. To find out more about breast cancer trials and our clinical trials research, visit breastcancertrials.org.au. To keep updated on the latest research, stories and breast cancer trials activity, make sure you subscribe to the Breast Cancer Trials podcast and follow us on Facebook, Twitter, LinkedIn and Instagram.